This podcast is sponsored by Zoll LifeVest. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Hello, CardioNerds. Dan Ambinder here. This episode is part of a series of fascinating case reports developed in collaboration between CardioNerds and the National Lipid Association, aka the NLA, with sponsorship from Dr. Daniel Soffer and Dr. Eugenia Gianos. Before we get started, I'd like to bring a special guest host, Dr. Devesh Rai, who is the chair of the CardioNerds Cardiovascular Prevention Committee. Devesh, so happy you can finally join us, and thank you for your leadership in this collaboration.
Dan, it's a pleasure to be here, and I'm so excited to discuss lipidology today. These cases are put together by the National Lipid Association Lipid Scholars, and joining us today we have two wonderful doctors, Alexander Razavi and Jelani Grant. Alex and Jelani, please introduce yourself, including how you joined National Lipid Association and how the Lipid Scholar programs fits with your career goals. The National Lipid Association runs a Lipid Scholars Program which aims to mentor and educate trainees to work towards certification during their training, getting more certified lipidologists and preventionists into clinical practice. We are really excited about lipids and hope you will be too. Alex, why don't you introduce yourself?
Thanks, Devesh. Alex Razavi here. I'm a first-year cardiology fellow here at Emory, but originally from Rochester, New York, big Buffalo Bills fan, and did my undergraduate training at Case Western in Cleveland, and then due to my interest in public health, went to Tulane to study medicine and public health, and fell in love with prevention living in the Southeast, where I think a lot of work continues to be needed in the prevention space. I had always had an interest in lipids, and coming to Emory, the opportunity came to pursue this Lipid Scholarship Program through the NLA, and it's been wonderful to be a part of the team, and looking forward to sharing insights here through the case with Jelani and Devesh.
Thanks, Alex. So I'm Jelani Grant. I'm originally from Trinidad and Tobago in the Caribbean. I did my medical school training there, then moved to the University of Miami, where I did my internal medicine residency training and the chief year. Trinidad and Tobago has the highest prevalence of cardiovascular disease in the Caribbean, and that's where I truly became passionate about preventing heart disease. I'm a second-year fellow at Johns Hopkins, super passionate about lipids, prevention, and anything related to risk assessment. So excited to spend this time with Dan, Devesh, and Alex.
All right, thanks a lot for that introduction. Let's get to the case and let us learn about lipids. Jelani, why don't you tell us about the case?
Yes, let's get started. So this was a patient we saw in clinic. She's a 23-year-old asymptomatic woman who presented requesting advice about treatment of mild hypercholesterolemia in the setting of a family history of severe hypercholesterolemia and premature coronary artery disease. Her mother and 30-year-old brother had severe hypercholesterolemia. Maternal uncle had a total cholesterol of between 400 to 500 milligrams per deciliter, and all of his children had high cholesterol levels, with one son dying at the age of 17 from a reported myocardial infarction. In terms of her dietary history, she was eating approximately 14 eggs per week, butter on her waffles at breakfast, and beef twice per week. But otherwise, she was following a heart-healthy diet rich in whole grain cereals, fresh fruits and vegetables, low-fat dairy products, white meat poultry, and fresh ocean fish. She trained in jiu-jitsu and did weightlifting for 90 minutes 5 times per week. She had no history of thyroid, renal, or hepatic disease and was taking no medications. She briefly smoked 3 cigarettes per day for less than 2 years, but had no other ASCVD risk factors. Her physical exam was entirely normal, and she had no corneal arcus, xanthelasma, or tendon xanthomas. Her lipid panel on presentation showed a total cholesterol of 228, triglycerides of 49, an LDL cholesterol of 148, a VLDL cholesterol of 10, an HDL cholesterol of 70, and a lipoprotein A level of 143 nanomoles per liter. She was advised to eliminate egg yolk and butter from her diet and limit beef intake to not more than 1 serving per week. After 3 months of dietary changes, her repeat lipid panel showed a total cholesterol of 192, triglycerides of 59. Her LDL cholesterol decreased from 148 to 126. Her HDL cholesterol was 54. Her TSH, BUN, creatinine, liver function studies, and urinalysis were all normal.
Thanks, Jelani, for this interesting presentation of this case. And this seems like a very common clinical scenario in our preventive cardiology clinic. So, Alex, what do you think? Has this patient escaped a diagnosis of familial hypercholesterolemia?
It is certainly possible. And I think important clues are her extensive family history of premature ASCVD, as well as her own elevated Lp(a). FH is amongst the most common autosomal codominant genetic conditions, and heterozygous FH occurs in approximately 1 to 200 to 1 to 300 individuals, whereas homozygous FH is rare, occurring in 1 to 160,000 individuals to 1 to 300,000 individuals. I think it's important to start off talking about screening and clinical suspicion first. When looking at the lipid panel, an LDL cholesterol greater than or equal to 190 milligrams per deciliter, or non-HDL cholesterol greater than 220 milligrams per deciliter in adults greater than 20 years old is suggestive. When looking at adults less than 20 years old, an LDL-C greater than or equal to 160, or non-HDL cholesterol greater than 190, especially in children and adolescents, is important to consider a diagnosis of FH. When talking about universal lipid screening, it is currently recommended by the AAP and AHA to screen all individuals 9 to 11 years for a standard lipid panel. Moving into family history, it is important to note a premature history of atherosclerotic cardiovascular disease defined as less than 55 years old in men or less than 65 years old in women. And, looking at family history of premature disease as well as the lipid panel, it is important to note that cholesterol screening should be considered as early as age 2 for children with a family history of premature ASCVD or hypercholesterolemia. And importantly, by age 20, it is recommended that all individuals should have undergone at least one standard lipid panel test to screen for FH. It is also important to consider physical exam findings, which are sensitive but not specific for FH. Tendon xanthomas at any age are important to consider, most commonly found in the Achilles tendon, finger and extensor tendons, but can also occur in the patella and triceps tendons. Corneal arcus in individuals less than 45 years old are also an important clue, as well as tuberous xanthomas or xanthelasmas in those less than 25 years old. Moving on into the diagnosis of FH, there are several validated criteria that can be used clinically when you see, for example, an LDL cholesterol greater than 190 on a lipid panel. And we'll briefly touch upon them here. First one to consider is the Dutch Lipid Clinic Network criteria. Variables here include family history, clinical history, physical exam, the LDL cholesterol level, as well as DNA, importantly functional mutations in the LDL receptor, ApoB, and or PCSK9 genes. Next is Simon-Broom criteria for FH. Variables here include total or LDL cholesterol, physical exam, and again, DNA or functional mutations in the same genes, LDL receptor, ApoB, and or PCSK9, as well as a family history. The third one, which is a little different because it is the only one of the three that does not require genetic testing, is the United States Make Early Diagnosis, Prevent Early Death, or MedPed criteria, which may work particularly well for cascade screening, given that no genetic testing is required. And variables here include age, total cholesterol, family relative, and the degree, such as first degree, second degree, and so on with FH.
Thanks a lot for going over the various clinical criteria for familial hypercholesterolemia. So typically in my practice, I divide the screening criteria in 3 buckets, which you went over already. So first is lipid profile, where very high suspicion of LDL levels more than 150 or 160 raises a high clinical suspicion, which prompts me to dig deep into the family history, going to the first degree specifically, but sometimes going up to the second degree as well. The third is looking over the physical examination finding, although the findings of corneal arcus or tendon xanthomas are not seen in all the patients, but when they are present, there is a very high index of clinical of suspicion to pursue further testing. Another thing which I find exciting about the familial hypercholesterolemia is even though there are three different criteria proposed, namely Dutch Lipid Clinical Network, Simon Broom, and US Make Early Diagnosis Prevent Early Death. However, sometimes some patients do not tend to fall in a specific criteria, and we need to have a high index of suspicion to proceed with further workup as needed.
Thanks for that thought, Devesh. I think one thing that also stands out, or a question that always pops up, is what is the risk of coronary artery disease in patients with FH? One study by Amit Khera and his group published in JACC in 2016 evaluated the diagnostic yield and clinical utility of sequencing familial hypercholesterolemia genes in patients with severe hypercholesterolemia. They showed that among 1,386 patients derived from 7 case control studies and 5 prospective cohort studies with severe hypercholesterolemia, which is an LDL cholesterol greater than or equal to 190, only 1.7% of patients with an LDL cholesterol greater than or equal to 190 had any FH-causing mutations. Using a logistic regression compared to CAD-free controls, patients with severe hypercholesterolemia had an odds ratio for coronary artery disease of 6, with a 95% confidence interval between 5.2 and 6.9 in the absence of FH-causing mutations. And this increased to a whopping 22.3 in terms of the odds ratio for CAD, with a confidence interval between 10.7 to 53.2 if a gene mutation, including an LDL receptor, ApoB, or PCSK9 mutation was present. A more recent study from January of this year demonstrated that among 21,426 individuals across 6 U.S. cohorts, including MESA, ERIC, CARDIA, the Framingham Heart Study, the Jackson Heart Study, that the presence of FH variants was associated with a 2-fold higher risk of coronary heart disease. The odds ratio was 2.9, and the 95% confidence interval was between 1.4 and 6, when LDL cholesterol was only moderately elevated, and that's an LDL cholesterol level of between 130 to 180.
Thanks, Jelani, for going over this data, which shows the importance of mutations in diagnosis of FH and how having a mutation will increase the risk of having a CAD dramatically. I'm really enjoying this discussion. It looks like you're putting the learnings of Lipid Scholar Program to work. So in a nutshell, we have this 23-year-old asymptomatic woman coming to our prevention clinic who is physically active, multiple family members having CAD in 20s to 30s. Her lipid panel was significant for total cholesterol of 228 and LDL cholesterol of 148. After 6 months of dietary modifications, her total cholesterol decreased to 192 and LDL cholesterol of 126. So Alex, given this lady's clinical presentation, do you think we should consider genetic testing in this patient?
Thanks, Devesh. I think it's definitely important to consider genetic testing in all patients presenting with FH. In synthesizing the data Jelani presented above in the setting of a few clinical pearls, we can review why that may be. Importantly, physical exam and family history are present in only a minority of patients with molecularly defined FH. And I think this is important to consider when reviewing the FH diagnostic criteria we reviewed earlier. In addition, family history may also be unreliable due to a reduced penetrance of a mutation and/or differences in lipid-lowering therapy over the life course with family members. In addition, family history may be unavailable in and of itself. And looking at the data, up to 45% of patients with molecularly defined FH may have an LDL cholesterol less than 190, whereas up to 27% may have an LDL cholesterol less than 130. So to summarize the clinical value of genetic testing, I think it provides important prognostic information. It may promote the initiation and adherence of lipid-lowering therapies, and it can also serve as a basis for more effective cascade screening in family members.
Thanks, Alex. The clinical presentation and this discussion is humbling. I'm learning so many pearls from both of you. In the current era, genetic testing has become easier compared to 1 or 2 decades ago, as there are multiple vendors out there performing genetic testing, and sometimes patients coming to our clinic with a request that they want to get genetic testing done because of multiple family history of early onset CAD. So over the years, after the clinical screening and when it's positive, genetic screening has been the next step. This can be essentially very beneficial in pediatrics and youngish patients. early identification of familial hyperlipidemia can be very helpful in prompting early initiation of preventive therapy, which will prevent future coronary events. So, Jelani, do you routinely perform genetic testing in lipid clinic for suspected FH patients currently?
Devesh, in our practice, we do. And especially in this case, the patient, the mother, and the brother, we did genetic testing. Specific to the patient, she had no physical findings of H. Her initial LDL cholesterol was 142 milligrams per deciliter. And we proceeded to genetic testing where she had a heterozygous mutation in her LDL receptor gene. In terms of the mother, she had corneal arcus and tendon glandulas on physical exam. And her initial LDL cholesterol was 199. And she was already on evolocumab, which is a PCSK9 monoclonal antibody. And she had the same heterozygous LDL receptor mutation. A brother who was younger had no physical findings either, and his initial LDL cholesterol was 232. And on genetic testing, he also had a heterozygous LDL receptor mutation. So to answer your question, I think based on the criteria Alex mentioned before, I have a very low threshold for genetic testing because if positive, it changes management and the prognosis is worse.
Thanks, Jelani, for going over these results. So, the identification of heterozygous LDL receptor mutation shows the importance of genetic testing for sure. So, Jelani, why did this patient with heterozygous familial hyperlipidemia only has mild hypercholesterolemia?
So I think the answer to that is one, cholesterol levels track upward with age. She presented at a very young age, had very heart healthy lifestyles, including her diet, jujitsu, and regular aerobic exercise. So who's to say in 10, 15, or 20 years that her LDL cholesterol would not track upward? I think the second thing is about penetrance of FH causing gene mutations, right? You can have a gene mutation, but if there's incomplete penetrance, it may not manifest the same way as perhaps her mother or her brother. And the last thing is she did have a heterozygous mutation in her ABCJ8 gene, which most times is a deleterious mutation, which increases ASCVD risk or LDL cholesterol. However, if it's overexpressed, that may have a LDL cholesterol lowering effect. Alex, can you help us review data regarding FH patients who are at the highest risk for coronary artery disease?
Thanks, Jelani. Interesting case that continues to evolve. Yeah, I think beyond genetic testing, there is certainly heterogeneity in this high-risk population, both in outcomes and long-term risks, which may be attributed to timing of lipid-lowering therapy, as well as other risk factors, including cigarette smoking, hypertension, and Lp(a), as we saw in this patient in particular. I think beyond traditional risk factors, one additional marker of heterogeneity that is not often as discussed is subclinical atherosclerosis burden, in particular coronary artery calcium or CAC. In a review of 9 studies published in 2020 in JACC Imaging, this included about 1,200 patients with heterozygous FH, 93% of which had molecularly defined FH. Mean age was 47 years, and about one half were women. Authors found that approximately 45% of this patient population had absence of CAC or CAC equals 0. And important to highlight here that the absence of CAC, even in heterozygous FH, confers a favorable prognosis. Diving a little deeper into these findings, looking at a separate study in molecularly proven heterozygous FH, which included 206 individuals receiving statin and ezetimibe, who were followed for a median of 3.7 years. Approximately 50% had CAC equals 0, and no ASCVD events were found during this follow-up period. Certainly questioning the follow-up time is important to consider here. And additional studies have been done in this space, looking at a longer follow-up time in separate cohorts, including the multi-ethnic study of atherosclerosis. In a separate study that was done among approximately 250 individuals with an LDL-C greater than or equal to 190, who were followed for a median of about 13 years. When comparing individuals with an LDL-C greater than or equal to 190 who had CAC equals 0 versus prevalent CAC, those with CAC equals 0 had a 75% lower risk of ASCVD events. So in total, I think definitely important to keep an eye out on traditional risk factor burden, but also subclinical atherosclerosis and CAC. And I think important to consider in considering healthcare value and prioritization of therapies for those that may be at highest risk. And we'll get into this a little later in the episode.
To add to what Alex just described, the Spanish Familial Hypercholesterolemia Registry was a multi-center study of Spanish long-term prospective cohort patients of molecularly defined heterozygous FH on contemporary statin plus or minus ezetimibe therapy with and without ASCVD. The registry was first developed to define risk factors and to build a risk prediction equation to help to discriminate patients who developed clinical ASCVD over time from those who did not. Among 2,404 adult patients with FH who were followed up for a mean of 5.5 years, during which 12 or 0.5% of the population and 122, which was 5.1% of the population, suffered fatal and non-fatal incident ASCVD. The strongest predictors of future ASCVD were an age greater than 60 years old, male sex, a history of ASCVD in the past, an elevated blood pressure, obesity, active smoking, an LDL cholesterol greater than or equal to 160 milligrams per deciliter, and an LP level A of greater than 50 milligrams per deciliter. A second study in JACC in 2019 showed the relationship of an LDL cholesterol polygenic risk score to cardiovascular events in 626 patients. These patients were from British Columbia with clinically suspected FH. A single causal pathogenic variant in an FH gene was identified in 44% of the participants, with a clear gradient from definite to probable to possible. Individuals with a monogenic etiology for FH had higher levels of LDL cholesterol and an approximate twofold higher risk of cardiovascular disease events. Among individuals without an identified single gene causal mutation, which was approximately 56% of the total group, 38% had a high LDL cholesterol polygenic risk score, which was defined as greater than the 80th percentile for the population reference. Although this group had modestly but not significantly increased LDL cholesterol levels, it did not have a significantly higher cardiovascular disease risk than those without a high LDL cholesterol polygenic risk score. Conversely, among those individuals with a monogenic etiology of FH, the coexistence of a high LDL cholesterol polygenic risk score was not associated with higher LDL cholesterol levels, but this did appear to be associated with higher cardiovascular disease risk. This study confirmed that a subset of clinical FH patients who have no identified single gene cause have a high LDL cholesterol polygenic risk score that explains or influences the FH phenotype, although approximately 34% have neither a monogenic etiology nor a high LDL cholesterol polygenic risk score.
Thanks a lot, Alex and Jelani, for going over these data. I'm learning so much from both of you. Thanks a lot for going over the role of coronary artery calcium score as well as polygenic risk score in FH patients as well. So we have this asymptomatic young woman coming to us for primary screening with the LDL levels of 148, which comes down to 126 with diet changes. She has multiple family members with early onset premature myocardial infarction. We have a high clinical suspicion, and we chose to pursue genetic screening in her along with her parents as well. The genetic screening comes out to be positive for heterozygous LDL receptor mutation in her brother, and her mother as well. It is interesting to know that her and her brother do not have any physical exam findings. This case brings out an important aspect of understanding the aspect of heterogeneity of familial hypercholesterolemia. This case also brings out an interesting aspect of variable penetrance and absence of physical finding despite having mutations in patients with FH. So, Alex, what are the current blood cholesterol management guidelines?
Thanks, Devesh. Let's quickly review the 2018 Multi-Society Management of Blood Cholesterol Guidelines. And I think important to highlight here in the 2018 guidelines, authors specifically held back from referring to FH because they stated that a high LDL cholesterol alone was sufficient enough to increase ASCVD risk. For the subgroup of patients, which they defined it with severe primary hypercholesterolemia or an LDL-C greater than or equal to 190, they recommended initiating high-intensity statin therapy without calculating a 10-year ASCVD risk with the pooled cohort equations. Recommendations then went on to include that if the LDL cholesterol was greater than or equal to 100 adding ezetimibe would be reasonable. And then if the patient on both statin and ezetimibe with an LDL cholesterol greater than or equal to 100 milligrams per deciliter still had difficulty with control and had a high background ASCVD risk, guidelines did note that adding a PCSK9 at this time may be considered. And at the time, PCSK9 inhibitor safety and long-term data was unclear. But I think moving on since 2018, it's been several years. And in 2022, the ACC published an expert consensus decision pathway on non-statin therapy, which is definitely important to consider in the setting of this case, and did further elaborate on the 2018 multi-society guidelines. And I think interestingly here provided a little bit more parallel schema for initiating ezetimibe and PCSK9 inhibitors, as the recommendations in this expert consensus decision pathway said that if even after initiating high intensity statin therapy for this subgroup of patients, if LDL-C control was still difficult, that either ezetimibe or a PCSK9 inhibitor would be reasonable and did not necessarily need to be initiated in a stepwise fashion, because by 2022, we did have more data and do have more data on the long-term safety and outcomes with PCSK9 inhibitors, notably Fourier and Odyssey trials with PCSK9 inhibitor therapy. In addition, I think it's important to highlight that the 2022 expert consensus decision pathway stated that some patients may require even greater LDL-C control beyond what was stated in the 2018 multi-society cholesterol guideline, which had an LDL target of 100. It's important to highlight here that the more recent document includes a lower threshold of 55 for patients with familial hypercholesterolemia. Jelani, do you want to further elaborate on the 2022 expert consensus decision pathway by the ACC, discussing a little and some of the new lipid lowering therapies that have emerged?
Sure. Thank you so much for that review, Alex. You know, we're all familiar with the statins, ezetimibe, and the PCSK9 monoclonal antibodies, as Alex alluded to. But now we have inclisiran, which is a novel small interfering RNA therapy that inhibits the production of PCSK9 protein. It is currently FDA approved in those with heterozygous FH who require additional LDL cholesterol lowering, as well as individuals with ASCVD and individuals with primary hyperlipidemia. Inclisiran reduces your LDL cholesterol by approximately 50%. It's administered by a subcutaneous injection twice a year after an initial baseline and 3-month dose. However, at present, we do not have cardiovascular outcome data available. Secondly, there's bempedoic acid, which is a novel oral non-statin lipid-lowering therapy that works by inhibiting ATP citrate lyase, an enzymatic reaction upstream of 3-HMG CoA reductase in the hepatic cholesterol synthesis pathway. It confers reduction in LDL cholesterol of approximately 18% on background statin therapy, and this increases to 21% in patients with statin intolerance who are not taking any statin, and further increases to an LDL cholesterol reduction of 38% when given in fixed dose combination with ezetimibe. The drug received FDA approval in 2020, and this was for patients with heterozygous FH who required additional LDL cholesterol lowering, as well as in individuals with ASCVD and individuals with primary hyperlipidemia. The CLEAR Outcomes trial was published in 2023 and showed a reduction in cardiovascular outcomes in patients with statin intolerance. However, it is important to note that our patient is a young woman of childbearing age, and we have to counsel patients on contraception and the potential teratogenic effects of statin therapies or other medications. While the FDA recently changed its guidelines on statin therapy during pregnancy, we did advise our patient to stop taking her statin when planning to conceive, but can be resumed after breastfeeding.
Thanks, Jelani. I think there are two other drugs that are also approved for homozygous FH, notably lomidopide as well as eminacumab, and we'll briefly touch upon these agents as well. Lomidopide directly binds to and inhibits microsomal triglyceride transfer protein, which is in the endoplasmic reticulum, and thereby prevents assembly of ApoB-containing lipoproteins in both enterocytes and hepatocytes. This inhibits the synthesis of chylomicrons in VLDL, leading to a reduction in LDL, and the mean percent change from baseline is approximately 40% when added to baseline lipid-lowering therapy. The lomidopide is FDA approved for LDL-C, total cholesterol, ApoB, and non-HDL-C lowering in patients with homozygous FH. And the initial starting dose is 5 milligrams orally and can be up-titrated to a maximum dose of 60 milligrams daily. Evinacumab is a monoclonal antibody that binds to and inhibits angiopoietin-like protein 3, which promotes VLDL processing and clearance of LDL formation. It is FDA approved for LDL-C lowering in adults and pediatric patients 12 years and older with homozygous FH as an adjunct to other LDL-C lowering therapies. This can be administered by a healthcare professional as an IV infusion once monthly. In addition to these two agents, I think it's also important to highlight LDL apheresis, which is an important therapy to discuss when reviewing FH. It is currently FDA approved for patients with FH unresponsive to pharmacologic and/or dietary management with functional homozygous FH when the LDL-C is greater than 500 milligrams per deciliter, functional heterozygous FH with no known cardiovascular disease, but an LDL-C greater than 300 milligrams per deciliter, or functional heterozygous FH with known CVD and LDL cholesterol greater than 200 milligrams per deciliter. With weekly or biweekly apheresis treatment, average LDL-C can decrease by approximately 50 to 60% of original levels. And important to note that LDL cholesterol does increase after each apheresis session, but does not return to the original level. It is important to continue managing these patients with the pharmacotherapies that Jelani and I mentioned above. I think overall, this is a very exciting time in lipidology and preventive cardiology. I think when interpreting the data on these new agents, as Jelani mentioned in inclisiran, there's new and important data published recently this month on an inclisiran first approach from the Victorian Initiate trial, which showed that initiating inclisiran first versus the standard approach to care as we reviewed in the expert consensus decision pathway by the ACC in 2022, that an inclisiran first approach achieved greater LDL-C reduction without discouraging statin use or raising new safety concerns from a recent RCT published in patients with ASCVD and JAK. So I think it's important to highlight that there are many ways that we can achieve LDL-C cholesterol control in patients with FH. There may not be a one-size-fits-all approach, but it is also important to follow the guidelines that we highlighted above. I think in addition, we should consider heterogeneity in FH when initiating treatment. For example, we reviewed data on subclinical atherosclerosis burden and coronary artery calcium in FH. And I think, for example, if a patient with heterozygous FH has a CAG score of 0, this patient is different from a heterozygous FH patient with a high subclinical atherosclerosis burden or, say, a CAG score greater than or equal to 300. Do these patients necessarily warrant the same approach to LDL-C cholesterol reduction? May not. And I think it's important to highlight with the patient on what their goals are and make this a risk discussion and have us achieve LDL-C cholesterol control together with our patients.
Indeed, Alex, you bring a great point about personalized medicine and use of individualized coronary artery calcium score and polyrisk scores to identify the patients and treat them with appropriate therapies. In the current era of cardiology, with the newer therapies for lipid management, these are exciting times for sure. When statins were discovered many decades ago, it was groundbreaking. But however, with the newer therapies like PCSK9 inhibitors and with the current phase 3 trials of inclisiran, I am looking forward to the results. Not only am I excited to see the results of newer therapies like evinacumab and possible use of CRISPR technology in this space as well, which has been widely talked about. Coming to our patient Jelani, what sort of long-term follow-up is required for this patient?
Devesh, I think what's important is definitely the first step is making sure that they follow up with a lipidologist or someone with experience or expertise dealing with familial hypercholesterolemia. This is going to entail serial measurements of a lipid panel, risk factor optimization, and ensuring cascade screening of first-degree relatives, I think is of paramount importance.
Thanks a lot for sharing this interesting case with us, Jelani and Alex. It was wonderful learning from both of you. So we had this young woman who presented to our clinic for screening of familial hypercholesterolemia. She had multiple family members with early onset CAD. So we'll briefly touch over the screening characteristic for familial hyperlipidemia. So when untreated, LDL cholesterol levels of more than 190 or non-HDL cholesterol levels of more than 220 in adults who are more than 20 years of old, or where LDL cholesterol of more than 160 or non-HDL cholesterol of more than 190 in children, adolescents, and adults who are less than 20 years of age. It is also advised for universal lipid screening by American Academy of Pediatrics and American Heart Association to screen them while they are 9 to 11 years of age. We should also pay attention on physical examination and take a detailed family history regarding any early onset CAD. Moving forward, whenever we see a patient like this with possibility of familial hyperlipidemia, we should also look in the diagnosis of family members for established familial hyperlipidemia, regardless of their cholesterol levels. This is where the importance of cascade screening and genetic testing comes in play. So we should have a very high index of suspicion, and if in patients with very high LDL levels, and when our index of suspicion is high, we should pursue genetic testing. Moving forward, in treating these patients, our goal should be to treat the patients with an LDL target of less than 100 at least. Although while doing this, we should also focus on personalized medicine and focus on other risk factors like coronary artery calcium score, polygenic risk score, and the response to the statin therapy, which we can start with as a first line statin therapy. On top of that, when the LDL levels are not at target, we can add Zetia, and moving forward, PCSK9 inhibitors and other therapies as needed. So our faculty expert for this interesting case will be Dr. Archna Bajaj. Jelani, would you like to introduce her?
Of course, thanks, Devesh. I met Dr. Bajaj at the University of Pennsylvania during an interview, and she was such a lovely person to discuss lipids with. She graduated from the Case Western Reserve University School of Medicine in 2012. Dr. Bajaj works in Philadelphia and specializes in genetic disorders and internal medicine, as well as lipidology. And she's affiliated with the Hospital of the University of Pennsylvania and Penn Presbyterian Medical Center. Dr. Bajaj?
Thank you to Dr. Razavi and Dr. Grant for presenting this interesting case. My name is Archna Bajaj, and I am a physician and researcher at the University of Pennsylvania. My training was in internal medicine, and now as a clinical lipidologist, I see patients with FH, high lipoprotein A, and other lipid disorders in our preventive cardiology program. So let's recap the case that Dr. Razavi and Dr. Grant just presented. This was a young 23-year-old female with mild hypercholesterolemia. Her LDL cholesterol on presentation was 148, and her non-HDL cholesterol was 158. She also had a high lipoprotein A, or LPA, with levels almost 2 times the normal limit. She was otherwise healthy. Her family history was notable for high cholesterol on her maternal side, with an uncle whose cholesterol levels were reported to be greater than 400, and his son, who was her cousin, who passed away at the very early age of 17 from a reported myocardial infarction. The first teaching point of this case is the importance of getting a complete history. As was nicely discussed in the presentation, identification of familial hypercholesterolemia, or FH, at a young age presents an opportunity for early risk factor modification to not only affect lifelong cardiovascular risk, but to delay or prevent the onset of disease in these patients for whom premature atherosclerotic disease is prevalent. Consider then how many of these opportunities are easily missed. This patient is a young female in her early 20s with no significant medical history herself, presenting without any complaints or symptoms. Her LDL cholesterol is less than 150, so by itself does not immediately raise suspicion of familial hypercholesterolemia. And the response, without digging further, may easily have been to counsel her on diet and exercise, and maybe return in a year to recheck a lipid panel. It's only by asking about the family history that we receive information that raises suspicion for a genetically driven risk for cardiovascular disease. But notice the importance of asking for a history beyond just the first-degree relatives. The patient noted that her mother and brother have high cholesterol, but the red flag in her family history is that her maternal uncle has extremely elevated cholesterol levels, and her cousin passed away as a teenager from a presumed MI. Especially since statins have now been in use for almost 4 decades, it is important to obtain a family history that extends beyond one generation and maybe beyond the immediate family. You may have a patient whose parents were treated and thus did not develop the classic early atherosclerotic cardiovascular disease seen in FH, So asking about grandparents and other relatives may shed new light on the patient's history. As mentioned, there is enormous benefit with early diagnosis of FH. Dr. Razavi nicely reviewed the 3 scoring systems used to diagnose FH: the Dutch Lipid Clinic Network criteria, the Simon-Broom criteria, and the U.S. MedPed criteria. No matter which criterion you ultimately use, the key is to take that first step to consider the presence of FH, meaning the presence of a genetically driven hypercholesterolemia when you see a patient such as the one described in the case, even with borderline elevated cholesterol. And remember, genetic testing can confirm the diagnosis, but is not necessary for making the diagnosis, meaning you do not need to wait for genetic testing results in order to initiate a treatment strategy. The risk with FH, and as discussed similarly with polygenic hypercholesterolemia, is driven by a lifetime exposure to high cholesterol levels since birth. The cumulative exposure predisposes to early atherosclerotic disease. Prevention is simple. Early initiation of treatment, such as statins, can modify this disease trajectory. Several cohort studies have shown that earlier diagnosis of FH leads to improved patient outcomes. Doctors Razavi and Grant nicely summarized the treatment algorithm for FH, starting with statins, and they reviewed all the non-statin therapies available now to our patients, including ezetimibe, the PCSK9 inhibitor monoclonal antibodies, as well as inclisiran. Patients with FH, particularly severe heterozygous FH, and of course patients with the homozygous form of FH, may require layering of several lipid-lowering therapies to achieve optimal LDL cholesterol and ApoB levels. When I first diagnose a patient with FH, I like to set expectations and counsel them that it may take more than one medication to achieve our treatment goals. Another key feature of this case is that we are speaking about a young female. Too often, I have a young female patient present to me with the story that her physician was reluctant to start her on a statin or other lipid-lowering therapy because of the risks in pregnancy. In 2021, the FDA removed its strongest warning against using statins in pregnancy, noting that in high-risk patients, there may be consideration of its use. In general, we still avoid using statins in most pregnancies. However, this is not a reason to not start a statin in a young female who is not currently pregnant. As I described, the risk with FH is the risk due to the cumulative lifetime exposure to high cholesterol. Delaying treatment until a female is past her childbearing years will necessarily miss up to a decade or more of treatment in affecting that cumulative exposure to high cholesterol, which can trigger the atherosclerotic process at a young age. With appropriate counseling, a female can and should be adequately treated in order to achieve optimal LDL cholesterol levels before and after any pregnancies. I mentioned genetic testing is not necessary in making the diagnosis, but it can confirm the presence of FH and offers valuable information. Genetic testing is widely recommended by most international guidelines and has a Tier 1 recommendation from the CDC. Genetic testing can be especially helpful in facilitating family screening. A positive genetic test showing presence of a pathogenic variant in an FH-causing gene should trigger family cascade screening, as was done in the case presented. Until universal FH screening is better established, family cascade screening offers an opportunity for early identification of patients with FH and initiation of prevention strategies before disease onset. So in the presentation of this case, Dr. Razavi mentioned one additional lab finding, the lipoprotein A, or LPA level. This patient's LPA was almost double the normal level. Just as a reminder to everyone, LPA is another proatherogenic lipoprotein. Levels are largely genetically driven. The risk associated with LPA is independent of LDL cholesterol levels. So in patients with FH, this risk is additive to the risk of cardiovascular disease associated with their FH. Presence of additional risk factors or risk enhancers like elevated LPA should push the needle in patients with FH when considering initiation of treatment or in setting lower treatment goals. To summarize, I think the most important takeaway point from this case is that early recognition of FH in a patient presents a prime opportunity to prevent cardiovascular disease in this high-risk population. Thank you to Dr. Razavi and Dr. Grant for presenting such an interesting case and one that I hope will impact the clinical practice for all of our listeners. And thank you to the CardioNerds panel for the invitation to speak to you today.
Thanks for tuning in to another CardioNerds episode. The audio editing for this episode was performed by me, Pacey Wetstein. I am an intern in the CardioNerds Academy, House Jones, and an MS1 at LeComm Seton Hill. I invite you to check out the episode page for show notes and references. If you found this episode informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our upcoming episodes. And now, it's time to make like an S2 and split.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.